I'm gonna do this right now so I can breathe.
All right, we're here. Sorry, distraction. Welcome. Thanks for joining ISSBT fans. We're getting pretty deep into our series now. Today's topic is going to be hip bursitis, otherwise known as lateral hip pain, otherwise known as greater trochanteric pain syndrome, a whole bunch of names, but hip bursitis is kind of the most common reason we talk about it. Covered a lot of different content up to today. We've only got one more video left. It'll be later this week, Friday. But today's topic, again, we're going to talk all things hip. This area, very common. In fact, it's one of the more common reasons in therapy that we're seeing folks for hip pain. It accounts for roughly 20% of all visits to physicians for hip pain in general, being second only to arthritis of the hip. Oftentimes, arthritis can refer to this area. So when we talk about hip bursitis, we really do need to confirm that it's the bursa or that region that's referring pain compared to the hip joint itself, because the treatment approaches, both with therapy and or any other intervention, is going to largely depend on what structural anatomy is maybe driving some of those symptoms. When we're talking about outside of the hip pain, we're talking literally very focal pain right in the very side of the hip, right where we have that bony aspect of the side of the hip. That area and just above or surrounding is very, very tender, okay? That area does have 3 different bursa. And when we talk about bursa, a bursa is just a fluid-filled sac that helps to separate 2 different surfaces within the body and helps things glide and reduce compression and make sure that any kind of friction that's in that area from tissues moving around can do so well. But occasionally, if there's too much stress in that area, the bursa itself can inflame and swell, and if left that way for a long period of time, chronically getting irritated, it can thicken and stay, somewhat almost permanently irritated. Now, the funny thing is, when we talk about hip bursitis, it's actually rarely the bursa that's driving symptoms in this area. 15 years ago, everybody that was referring people for side of the hip pain was suggesting that it was the bursa that's inflamed and irritated. And over the course of the last several years, exploring the diagnostics of what actually is happening in the hip, we're finding that really maybe only 20% of the time when you're having that really focal pain in the side of the hip is actually the bursa that's inflamed or the bursa that's driving the majority of the symptoms. The remainder of the time, it's actually the glute muscle tendons that are becoming chronically irritated and potentially leading into a degenerative tendinopathy where the tendon itself is chronically overstressed, overused, and potentially compressed, and that can lead to the bursa itself becoming irritated. But the main driver and the main problem is actually the tendons of those glute muscles as they tie into that area. So truly, for the majority of people that are experiencing this side of the hip pain, it's not the bursa, could be, but it's more likely that gluteal tendon that's starting to refer symptoms. And that makes sense, because the majority of the reason why we start getting symptoms in this area in the first place isn't just because all of a sudden you decided to have pain or genetics, but frankly, it's usually from some sort of mechanical overload. So you've been doing too much to irritate that area, or you've had a specific quick increase in activity, like you haven't been doing much, and then you decide to go on an 8-mile hike, and then it gets inflamed. But it's not the bursa itself that got inflamed; it was those tendons being overstressed and overused. We can differentiate the two still with just a couple simple tests that I'll show you in a moment. Kelly will be our model again today, and I'll show you how you can quickly potentially differentiate between if it's the bursa or the tendon. Either way, though, the treatment is nearly identical because we need to take that area and normalize the glute muscles and improve the tendon's tolerance to stress and unload it to an extent to let it calm down. And so both of them tend to do well with the same types of treatments. Again, we need to be cautious that when we talk about side of the hip pain, it's not something else like arthritis in the hip, which oftentimes can be more pain in the groin area too. It's not a pinch, we can get an impingement in the hip too, where when you kind of bring the leg up into the side, it hurts again right in the groin. But also this side of the hip, if we have an issue in the low back too, specifically at that L5 to S1, the lowest portion of the spine, if there's an issue there with the disc, the joints, pressure on the nerve, any of those things can actually refer symptoms down and around into the side of the hip. So it may not even be a true hip problem unless it's been screened and we've looked at it. So a lot of different things can masquerade as bursitis, but it's not bursitis, maybe something else truly. But there are some simple tests that you can do to determine if this is it. So if it's true lateral hip pain, almost every time that this is inflamed, you'll have pain. When you are sitting for an extended period of time and then stand up, it'll be worse. You'll have pain after you've been standing for a long time or you've been walking. You'll have pain if you stand and balance on one leg, specifically up to 30 seconds. You'll have significant pain in that spot. You typically don't have pain when you put on socks and shoes, and that's a big differentiator with other issues in the hip, specifically arthritis, where it's usually painful to do something like that, whereas it may not be painful with this. And then really specifically, it just hurts when you press it. So when you get in that spot and you press it, it's like a lightning bolt. I mean, it is like, that is the pain. Do not do that again. In fact, clinically, we call it the jump sign, where I touch it and you want to jump off the table because it's so bad. Those are all clear differentiators that this is a hip bursitis or gluteal tendinopathy that's driving your symptoms. So that's my little intro about it, but the key is, what do we do about it? And a lot of these videos, we've talked about how is PT best. But obviously I'm biased because this is what I do, but there's more and more research supporting how treating hip bursitis or gluteal tendinopathy really should be brought to a conservative means with specifically therapy, more so than any other practitioner, because of the different types of interventions that tend to work well and how they work in conjunction well with each other on addressing all the confounding factors related to this pain. Specifically, again, getting in and exercising. Because the vast majority of symptoms with this are likely coming from those gluteal tendons and muscles, the gold standard treatment for treating a tendon issue is specific exercise, and specific exercise in the sense of how do we apply it, how long do we apply it, and how intense is it, and when is it okay to have pain. And all those things need to be monitored and progressed appropriately so that we're actually working those areas and improving the tension and tolerance of those gluteal tendons so that it isn't as painful when you're doing activities. That has to be a component of the rehab when we're talking about a tendinopathy. There's really not much else that makes it feel better, especially long term, unless you get in and actually address the strength and tension tolerance of those tendons. And that comes through exercise. And there's no better profession for it than PT. So exercise does work. What we saw was from a large systematic review just 2 years ago, when we looked at the comparison between getting steroid injection in the hip and specific exercise, and then everybody getting the same type of education and activity modifications, found that after 2 months of exercise and 1 steroid injection, at 2 months, they're basically the same, okay? Which, okay, when you get an injection, you tend to get maybe up to 3 months of symptom relief. So that's, okay, good. At 2 months, they're the same. But after a year, the exercise group showed significant improvements in pain, medication use, and functional mobility compared to the steroid group. So after those 2 months, you just do better if you're actually working it, because you're addressing the underlying issue and it tends to stay better and doesn't creep back. So we know that PT is already better than just getting a steroid injection in that area and modifying your activity. Additionally, when we look at the use of steroid injections for bursitis of the hip specifically, not necessarily even gluteal tendinopathy, when compared head-to-head, specifically with dry needling, which I'm going to talk about on Friday a little more thoroughly than today, when we compare the two interventions, they're literally identical with the outcomes. So this came from a study 3 years ago where they looked at literally that. Side of the hip pain, you get trigger point dry needling or you get an injection. And after 6 weeks, they're identical. Identical in pain, identical in functional outcomes, identical with medication use. And a lot of that is thought to come from the fact that putting the needle in that area is what makes the change. And so whether or not you inject something into that area or not, it's actually the presence of the needle facilitating and changing the tissue in that area and facilitating and changing pain, which is why the dry needling itself is equivalent. So we know that we can have similar outcomes and frankly less risk of an adverse effect, because now you're not getting the steroid medication in that area, because that's not without its risks, which we've talked about in prior episodes, but again, there are, it's not a silver bullet fix, getting an injection, because it does come with consequences to that connective tissue, especially if we do have a tendinopathy, which is already weakened connective tissue, which is further weakened by the steroid injection. Now, again, I've kind of gone through a lot of material so far, and I think it's time for some exercise. Like, we got to get engaged. We got to get engaged here. So, I'm going to show you guys 3 exercises today that are perfect for getting into that gluteus medius muscle, which is oftentimes the muscle, gluteus medius and minimus, which are the muscles that sit right here on the side of the hip and tie into that spot. There are best exercises to do that based off of studies that look at what muscles are recruited with certain exercises. I'm going to show you 3 of them that are perfect for getting into that spot. And then to finish the day, I'm going to show you some modifications or changes you can make to sleep positions, because one of the main issues with side of the hip pain is that sleeping on that side is darn near impossible. And so we want to make some modifications to sleeping positions so that you can offload that spot and get a good night's sleep. Okay. We're going to steal Kelly and show you these exercises. I'm going to have Kelly jump up on here and lay on your side here. So first exercise we're going to show you are clamps. Now, we've actually done some of the exercises that can work this area already. If you go back and watch our anterior knee pain video from 2 weeks ago now, we cover some stuff similar to this. And we did do clams already too, so there's progressions and regressions to that too. But we're going to show it again, because the clam exercise, when we look at what's recruited and then specifically what's not recruited, it's a great exercise for starting out to work the areas that we need to work. If you've been doing exercise for a while for this may be obsolete, but if you haven't started anything yet, this is a great exercise to start with. For that clam exercise, we start off with the legs bent, heels are together, heels, hip, shoulder, and head are all lined up, right? And you're perfectly on your side, okay? You're not rolled backward and you're not rolled forward, right? So Kelly's in a great position here. The exercise in motion itself is pretty simple, right? We're keeping the heels together and we're lifting the knees apart, right? And then controlling back down slow, okay? Notice what she's not doing, which is if you lift up, sometimes the compensation will be to kind of rotate your hips back, right? Again, we're kind of cheating the motion there a little bit, so we need to keep the hips stable as we lift up and down. The other thing is not just only with hips, if you lift and your whole body kind of rolls back, right? Again, you're not getting as much of that movement through the hip, so we need to make sure that your whole body stays stable, heels stay together, and you're just lifting as high as you can move through, and then control back down. Now, if you're noticing that this is painful, that the first thing I would suggest is that it's likely just because you're actually probably going through too much motion with it. One of the things that we see consistently with this issue is that when you lay on your side and your knees are together, this comes up when we're sleeping too, is that once your knee kind of crosses midline, when it's kind of dropping down here, it compresses in that spot. Because if you think about some of that tissue that goes right over the top of the hip, I mean, it rolls over the top. And when this is down and the rest of your hips are angled down, you can see this is the highest point, and it's kind of stretching out over that spot, but that's compressing the tissue underneath. So if there's a compressive problem, you're going to notice more symptoms. But if we bring the knee up and it's flat, we take some of the tension and compression off of that area. So if you have a pillow, thank you, right, and you put that between your knees, and you do that exercise from here, you're never kind of going into that range where it's tensioning but also compressed. So this is one of those moments where a partial range exercise is likely better than going through the full range, because we're not creating that tension as it's being compressed. Okay. Again, spoiler alert, this is a good position too for sleeping, but we'll come back to that specifically in a moment. Okay. Again, this can be progressed with putting a band around the knees, or at some point bringing the heels apart, but this is something that can be good for literally several weeks, just going through this repetitively. The second exercise is going to be a straight leg raise from the side. Okay, this is kind of a progression of this as well. Again, this exercise is shown to have a very high amount of that gluteus medius activation. We keep that bottom leg bent still just so you have leverage. You're going to think about leading with your heel with this one. So again, you want to make sure that ear, shoulder, hip, knee, ankle are in a straight line. Okay.
to get slightly more gluteus medius recruitment, which is what we want, because we want to put tension to that tendon, we internally rotate the hip a little bit. So we kind of point the toes in and down. See how our toe is pointing down? I'll tell you, if you've never done this before, your tendency is going to want to be to bring it up and out like this. Because when we externally rotate like that, we can use that kind of larger, bigger gluteus maximus muscle to assist with that movement. But we want to keep it in. You're not going to be able to go through as far of motion when you do it that way, but if you keep it turned in and move up and down through that motion, only going until your leg is straight up and down, there, and back up, we're getting excellent recruitment of that gluteus medius muscle. Now, one of the things I haven't talked about yet with the last exercise or this one is the reason we're choosing these exercises over maybe some of the others is that we know we get really high levels of recruitment of that muscle we need to work. But what we're not getting, go ahead and relax, is a heavy amount of recruitment of a muscle that sits just in front of that, called your TFL or tensor fasciae lata. It sits a little bit more in front of that spot that's tender. It's not every time, but oftentimes as we develop more of these gluteal tendon issues, that muscle tends to kick in and substitute for some of those glute muscles to take the pressure off. But what we know is that causes more compression over that site by kicking that area in. So we ideally don't want a lot of TFL recruitment with our exercises. We want those glutes to get engaged, not have the TFL. And when we look at the ratios of these muscles working through these exercises, it's like, oh, we don't get a lot from that TFL, but we get lots from glute. It's perfect. That's what we want. We want to facilitate those types of motions. So with the clams, it's an excellent ratio and real good glute exercise. For the straight leg raise on the side, toes pointed down specifically, excellent recruitment of gluteus medius, minimal recruitment of that TFL. Both these exercises, we want slow movements, especially to start, if not isometric or just prolonged holds. So in these early phases of recovery, we don't want rapid motions. We want slow, sustained, and amounts of tension. We want roughly 12 to 15 repetitions if you're doing them for repetitions. Start off with 1 or 2 sets only, see how you respond. Maybe working up to 3 or 4, 5 of them kind of maximum. If you're doing a hold, shoot for like a 40 to 45 second hold, which is actually going to be quite tough. For instance, if you do that straight leg raise and you turn the toe in and you hold in that position, you hold that for 45 seconds and you tell me you're not tired, you're probably lying to me. So this is going to get tough, right? So you can try that, but again, with any of these exercises, attempt to avoid doing it too low. So what we would not want to do, we don't want to do, is do a hold where it's kind of down here and the leg is angled downward, because again, that's going to compress into that site. Okay, so we need to keep it up and away. Okay, go ahead and relax. So clams, straight leg raise on our side. 1, 2, maybe 3 rounds of 12 to 15 repetitions, but very slow performed, if not holding it for 45 seconds, 45 seconds for a hold, okay? In these early phases, if it's really angry, the hold might be a little bit better in the sense that sometimes it can help with the pain and not be as irritating. All right, so here's our last one. We're going to actually use the step over here for this. You don't have to use a step, but it's better when you use a step. So Kelly's going to step up here, and we've been working her left side, so we're going to keep that consistent. She's actually going to go ahead and face Amy, so go ahead and turn your side. And we're going to do a hip hitch, okay? This is an interesting exercise. It can go rogue, and so performing this well kind of matters. But we're going to step using the edge of a step or a stair. Again, you don't actually have to use anything. You can do this from the floor, but your right side or unaffected leg is going to be hanging off of a box or a stair, and affected side is on it. And what you're going to do is try to hike that other hip like that, keeping your body tall, okay? And you're lifting up and holding tall. Now what I'll tell you you're going to do to compensate is you're going to feel like you're lifting it, but sometimes you may lean towards that side, or you may lean away from that side, kind of making you feel like you're lifting your leg, but you're really not. You're just kind of doing an abdominal crunch. But that lift of that other leg, kind of driving the whole pelvis upward with the affected side as the stance leg, is again one of these exercises that we see through science to really hit that area hard while getting minimal recruitment of the areas we don't want to kick in. Again, it's best performed on a small step like this, where again you have some support, but it doesn't have to be. You can do it from the floor and just lift up, just from the floor itself. Same concept. But you do need to stay tall. You do need to maintain, just that midline where you're not leaning to either side, and just lifting that up as high as you can. And perform this similar to how you would the other exercises. It doesn't have to be different just because of different exercise. 12, 15 repetitions of it, 1, 2, 3 rounds of it, or you can do it as one prolonged hold, right? But just watch that position when we do this. So those are our 3 exercises. We've got clams, we've got the straight leg raise on the side, and we've got our hip hitch exercise, okay? Now there are many, many others. There are so many other exercises. Again, even if you go back and you look at, again, the anterior knee pain one, we did the sidestepping with bands. That's another great exercise for this. More advanced exercises that we won't demo today that you could leverage to that, again, show a high level of muscle recruitment, but minimal TFL involvement, are doing things like single leg deadlifts or single leg squats, or doing a wall ball squat against the wall, or maybe doing a side plank where you're laying on your side and you lift your body up and you hold a straight position. If you're familiar with those exercises and you feel like you need the next level of exercise to work you, those are great ones to go to because they work more joints and they're harder to perform, but they do still get that same ratio that we want, okay? So those are our exercises. Give those a shot. When we talk about a tendinopathy, this has come up with other courses too. A little bit of discomfort is okay, but we just want to watch the resting levels of pain later in the day, and we want to watch pain the next day if it's that it's not increased. If you're noticing more or higher levels of pain afterwards, it's likely too aggressive the approach, and we need to modulate. Okay. Lastly, we want to talk about our sleeping positions. Okay, so we've talked about what this is, what it could be, exercise itself, PT. But let's get into sleeping positions, because this is probably, if not the most common complaint that we get with this, is like, I can't sleep. Like, okay, I'd like to go for more walks, but really I just can't sleep. So we need to figure this out, right? So we've got a couple modifications that we can make that will be helpful for this. So let's jump back on the table. The first thing I would suggest is being on your back. Okay. Again, if all things being equal, if you can sleep on your back, right? just that simple. Your body will move throughout the night. There's something like on average 18 times or something like that. I read that somewhere. But we move around a lot. So if you're in this position and you can tolerate sleeping on your back, one of the things you can do that's both comfortable and may keep you from moving around specifically onto your side as much is taking an extra pillow, especially like a fluffy one, and popping it under your legs, okay? And then straighten your legs out. That position kind of unloads your back a little bit. It's nice, it's comfortable. You can just kind of hang out right here, right? Kelly's gonna fall asleep on us today, right?
Yep.
Right? But the fact that you are propped in this manner and legs are elevated, your body is gonna find some resistance throughout the night actually attempting to roll, right? Because if you try to roll here, you're gonna notice it's like, it's kind of uncomfortable and your legs are gonna be kind of propped up higher. So your body's gonna know that when you're sleeping. So if you prop your legs up, you're both more comfortable and you're more likely to maintain on your back throughout the night. So try this first. Now I know some of you, it's like, I can't sleep on my back. I have to be on my side. Like, Steve, what can I do if I have to be on my side? It's like, well, there's really no way around sleeping on that side. There are some there are specific pillows you can order from online. Frankly, I'm not a fan of most of them, but there are specialized pillows that look like donut rings that you can get, and you can literally sleep on it. So that way the area around the side of the hip is kind of opened up around that donut hole, and so you can sleep on that. But the problem is you still encounter a lot of the same issues, which is you tend to shift off of it in the middle of the night, and then you're lying on it, and then it gets painful because you're sitting there compressing it all night. So there's not a lot of great ways to offload it on that side. So we need to find a way, if you're a side sleeper, to tolerate being on the other side. It's like, well, conceptually, again, if you've never dealt with this, you'd say, well, shouldn't that just resolve it? I'm like completely off that side. But no, again, if we're dealing with a left-sided hip problem like on Kelly here, if she lays on her right side, so go ahead and we'll pop this out and go ahead and turn. Just like we talked about earlier, if she's sleeping like this, this leg is dropping down. And there's some tension in that area. So even sleeping on the opposite side and having the affected side up, a lot of patients will still report that morning pain or discomfort while you're sleeping. Especially because, again, you're not going to sleep in this perfect and conscious position where you're at right now. You're going to shift and you're going to do things like this. You're going to have this one back and you're going to be here. Now it's even more exaggerated. So what can you do, right? Well, again, the first thing would be pillow, like we did with the exercise. Big pillow in between, cradle with the legs, just like we have it here, to offload that area, right? Some people like a body pillow where it's extended up a little bit more so they can kind of have their arm resting on it, and you're less likely to have that leg shift up and over the top of it overnight if you have that big long pillow. So using something like that will take that pressure off of it. Again, for people that are really restless when they sleep and move around a lot, we'll get people reporting that they'll, from this position, just roll over on the other side at some point in the night. So that's where we would take extra pillow number 2, right? Amy, I'm going to steal you again. And take extra pillow, bam, right behind the back, okay? Specifically between hip and shoulder blade, right? So it's right in here. Because now if Kelly wanted to turn over at night, she's going to have a roadblock. She's going to have a speed bump there to kind of block her from rolling over. So I know we got a lot of pillow system going on here, but hey, if you're injured and we need this thing to recover, it's worth it, right? We need some time to let this thing calm down. So take the time to set up your pillow system so you can optimally sleep. But having that extra pillow behind you keeps you from rolling over onto it. It's still comfortable if you end up rolling over onto your back in the middle of the night. You're still kind of supported, right? So this is kind of setup number 2 for sleep. Pillow between knees and pillow behind back so you don't roll over on it. That's taking kind of a general concept that we've always had, which is pillow between the knees, and make it a 2.0. Okay. So try those 2 positions. If you can tolerate on your back, that is preferred compared to your side. So on the back, pillow underneath the legs, or there are 2 pillow system here for on your side. Covered a lot of content today. Sleep, exercise, what the heck this thing is, other things it may be. Have we had any questions so far? It's been a couple videos now since we've had live questions. We must just be like super thorough. I love it. People just down taking notes, right? There are a few other things. I kind of will leave you with some other specific thoughts too, because this is kind of standard education that we give anybody with this issue, whether it's a bursitis or a tendinopathy issue. You want to avoid a couple things, and so kind of think of them as like 3 different silos of things that you don't want to do. One is related to sleep. So we don't want to sleep on that side and we want to unload it. So you want to be sleeping like we did now. Not sleeping on that side, sleeping either on your side or on your back. And if you're on your side, it's affected side up, pillow underneath. You need to have that pillow underneath. So sleep education. The second is with any kind of slope or stair. So we want to minimize slopes. So going for hikes right now out in the foothills, I know it's a great way to get outside, but if you're experiencing this, again, especially if it's a new onset of symptoms, you probably want to minimize the upslope, right? Just because of the way those muscles are contracting and putting stress into that area. Same thing with going up and down stairs. Save your trips, make sure you're kind of doing all the things you need to, not having to do multiple flights throughout the day. And lastly is crossing the legs. So we don't want to sit with your legs crossed. Let's go ahead and sit up. And we'll face here. We don't want to sit with legs crossed either like this, especially, right, where they're one over the top of each other. I know it's ladylike, right, but it's better to probably just sit with knees together, right, because it just puts less compression over that hip. So not crossing over the top like we just had, or sitting with it kind of pulled up higher in this manner either, right. Now this usually is better tolerated than the other type of crossing. However, we just don't want a lot of that crossing phenomenon, whether it's the other way or this way. It just puts more pressure in that spot over a prolonged period of time. So we need to unload that spot, give it a chance to calm down. We can do so by minimizing stairs and slopes, not crossing, and not sleeping on that side. Okay, those are 3 important concepts that you need to do just to unload that area so it can calm down. So in addition to some very specific graded exercise, and especially with this dry needling, it's very helpful. Didn't talk a lot about doing instrument assisted work on it today, but that is a very, very helpful adjunctive tool for specifically if it's a tendon issue. With the Bursa, it's kind of a crapshoot. Sometimes with the Bursa, it can be irritating. Sometimes with the Bursa, it needs to be unloaded and improve the soft tissue around that site to reduce the compression, so it can improve by using tools to kind of work that area and that soft tissue to open it up. But with the tendon, that cross-friction massage or instrument-assisted soft tissue work like we use here with A-Stim can be very helpful, and oftentimes, again, another tool to make this area feel better. But can't stress enough the importance of exercise and unloading it to get it better. So hope you found this helpful again. And leave your comments if you didn't get a chance to while you're watching, or if you watch this later and not live. Please leave your comments. We'll get back to you. Otherwise, enjoy, and hope to see you guys Friday for our final one of this series. And I've got another announcement for some future stuff coming up that I'll announce on Friday as well. So see you then. Talking dry needling. Thanks, guys.